Good morning. Today we are going to discuss the spine biomechanics and its clinical application. The objectives of this talk is to discuss the function of the spine and how it performs its function under physiologic loads. The basic functions of the spine is to maintain a balance in a stable situation, load bearing capacity, flexibility of motion in different directions, and protection of the neural elements. The balance and the stability of the spine will be discussed in both coronal and sagittal planes. If the spine is unbalanced in the coronal plane, then both pelvic wings will not be parallel to the ground. The shoulder will be of unequal heights, and there will be compensatory curves as well. Why this happens? It happens because of scoliotic deformity, trauma or tumor, or limb length inequality. The sagittal spinal imbalance is due to loss of anterior height of the vertebrae. Loss of the anterior height may be due to the fracture or infection or tumor eroding the bodies, or failure of the posterior elements like in Barre's defect and spondylolisthesis. The second component to provide stability of the spine is the tension band principle posteriorly created by the muscles, tendons, and the bony processes of the facet joints. A belly or increased abdominal dimensions will move the center of gravity forward and exhaust the posterior tension band elements. What is the moment? The moment is the effect of a load over a distance. If you move the object away from you, you can't hold it for long. If you move it near to the center, then you can hold it for long. A healthy spine is a load-sharing structure, and it helps to maintain the stability of the spine. These terms we should know. What is the length and how we measure it? What is the force, the stress, frequency, and the moment? Why the spinal column is a load sharing, not a load bearing? Because the anterior column share 80% of the weight applied to it, while the posterior column shares about 20% of the loads applied to it. The flexibility of the spine allows it to move in flexion, extension, left side bending, right side bending, left rotation, right rotation, or combination of all these movements. The forces applied to the motion segment are either tension, where both bodies are pulled apart, or compression, where both bodies are brought together, or rotatory in torsion, or in bending, or forward movement and backward movement as a shear force, or a combination of all these forces. The motion segment, which is composed of two adjacent vertebrae, the joints in between, and the disc and the muscles posteriorly, it has got actuators, which are the muscles that moves this segment, levers where the body or the processes are used, the pivot where the center of motion takes place in the disc and the facet joints, and restraints, which are the ligaments. The disc, which is placed in the disc space, is a very major important factor in spinal stability. It acts like a shock absorber. It it's a ball-bearing joint. It allows movement in all directions. It is composed of the annulus fibrosus and the central nucleus pulposus. Posterior muscle group, which is the dynamic tension band, is composed of superficial, middle, and deep layers, and stripping of these muscles may result in loss of sagittal plane balance. The tendons are part of the strains that are present in the motion segment, and they are connecting the muscle to the bone. The effect of the force applied to the motion segment will result in different outcome depending whether it is anterior or posterior. Anterior compression will cause kyphosis, anterior distraction will cause lordosis. On the back, and compression will cause lordosis, distraction will cause kyphosis. Constructs used in spinal surgery are either load-bearing or load-sharing. The best is load-sharing since it's more biological and it allows early fusion, while the load-bearing one is a stress-shielding construct and it needs to be stiff, strong, and biologically is not sound. Delayed fusion or breakage of the implant may take place. As we said, normally anterior column shares 80% of the loads, posterior one 20%. If you use a posterior construct only without anterior column support, then it is almost 95% load bearing and failure will take place. If you support the anterior column, then it is more physiologic and biologic. 80% of the weight is transmitted anterior, while the posterior takes 20% of the loads. These three diagrams shows the load sharing and load bearing constructs. The one on the left is a load bearing construct, 100%. If you apply an anterior support, then it is 80 to 20%. If the screws are long enough to support the anterior implant. If it is not long, then it is reduced to 65 anterior and 35 posterior. So what is the modulus of elasticity? As I said, it is the measurements of the stiffness of the material, and it depends on the material and the shape or geometry of the material, whether it is rectangle or rounded or whatever. It is important because for load sharing or load bearing devices, whether you need stiff or non-stiff implant, for the ideal load sharing devices, it's better to have a modulus of elasticity between cortical and cancellous bone. This diagram is very important in choosing the material for implants. It measures the modulus of elasticity of different implants. We can see the ceramic is the worst material for elasticity. It is brittle. Then cobalt chrome is better. Stainless steel is still better, until we go to cancellous bone, which is the optimum, like nature. The polymers are less than the cancellous, but better than cortical bone. Carbon fiber in the middle. Titanium is better than stainless steel or cobalt chrome. By definition, the yield point is the point where strain occurs without significant increase in stress. Ultimate strength is the maximum load a material can withstand without failing or breaking. The failure point is the catastrophic failure of the material where breakage would take place. So what are the options we have to choose among material to construct or to design a device or a construct to stabilize a given motion segment? We have the stainless steel, we have the titanium, cobalt chrome, or shape memory alloy. These are the metallic implants or material we can use in manufacturing our implants. If you compare titanium versus stainless steel, titanium has got advantages. It is better MRI compatibility because most of the patients may require MRI after surgery. So it's better to have a titanium implant. Less artifacts. Titanium has a higher biomechanical compatibility. Titanium is more brittle than stainless steel. It is more flexible, so it is less stiff than stainless. Titanium was introduced to the orthopedic surgery in the 70s. Commercial pure titanium comes in 4 grades. Grade 1 and 4 are used in spinal instrumentation or implants. It is often alloyed with aluminium and vanadium for better strength, titanium 6, aluminium 4, and vanadium. Titanium has got advantages and disadvantages. Regarding the advantages, it is strong, available, biocompatible, imaging with MRI is good, and high corrosive resistance. Regarding disadvantage, it is expensive, more difficult to manufacture than stainless steel. If we come to cobalt chrome, alloys have been used in surgery since 1920s. It is made of cobalt 70 to 75%, chromium 25 to 30%. It is very stiff. It is primarily used in weight-bearing applications like arthroplasties or disc arthroplasty. Advantages and disadvantages of cobalt chrome. It is difficult to fabricate. You have to machine it. High modulus of elasticity. And imaging with MRI is difficult. But advantages, it is biocompatible with the human being, resists corrosion, and there is a high long-lasting history of usage with less side effects or drawbacks. The SMA or shape memory alloy, it is getting used in spinal surgery more and more. It has the capability to change shape with temperature. It is made mostly of nickel alloy with smaller amounts of other elements. You manufacture it in the shape you want, and when you put it in the temperature, which is the human being temperature, it regains its original shape. So if you are using it for correcting spinal deformity, it comes in an S shape if you are dealing with scoliosis. Then you straighten it outside the body and correct it, put it in the advantage and disadvantage of the SMA, and once it reaches the temperature of the patient, which is 37 degrees Celsius, then it starts to regain its shape, good corrosion resistance, and it changes shape according to the body temperature. What about the PEEK? It is a polymer, polyethylene ether ketone. It is used in cages, sometimes in rods. It's radio translucent, and in imaging, whether MRI or plain X-rays, it is friendly. It is very strong and available. You can shape it the way you want. Modulus of elasticity is ideal between cancellous and cortical bone. It is a permanent material. It does not dissolve. It does not transmit disease, and it is easy to manufacture, as I said. The drawback is the wear and tear. So to summarize, what are the biomaterials fully understood? The products we do have, and we have the bone, and whether product autogenous or bovine. We have the metals of different types: titanium, stainless steel, chrome, cobalt chrome, or the polymers, or the like the PEEK, or the composites like the carbon fiber. What are the surgical techniques needed to address any spinal problem? You have either an anterior surgery or a posterior surgery or a combination. In the anterior surgery, you can have an open wedge or a closed wedge. In the posterior surgery, still you can have a closed wedge or an open wedge. So it is depending mainly on the pathology you are dealing with. In this diagram, where you are closing the wedge through the posterior by resecting the facet joints or even the pedicle subtraction technique, then applying a posterior construct, you close the wedge, or you can open a wedge if you wish. So posterior surgery can be used to address lordosis or kyphosis. We will present some clinical cases where the discussed biomechanical principles of deformity and spinal surgery were addressed before, and I hope you will enjoy the outcome. A marked kyphotic deformity in a young girl, 14 years of age, and as we can see, there is attempt at surgery before through an anterior approach, but with failure. This is her plain X-ray, and the angle measuring around 70 to 80, and the MRI shows the pathology of the spine and the bodies. Also, we can see a broken screw of the previous surgery. This patient was tackled anteriorly, where an anterior release and distraction was applied with grafting between the adjacent bodies, and completed with a posterior instrumentation as a supplementary fixation to increase the stiffness of the construct. On the left before surgery, on the right after surgery. And I think it's a good correction. Another case where there is a congenital kyphosis And to address such deformity, you have to remove the apical vertebra in deformity and apply some distraction through the anterior and posterior compression as well. Post-op X-ray of the same patient showing how correction could be achieved through an anterior release only and posterior instrumentation. On the left, the pre-op clinical picture of the patient, and on the right, the post-op clinical picture, which shows good correction. The same principles could be applied to the cervical spine as well. This is the patient with a kyphotic cervical spine, and there is no motion at the lower segments. And this is his clinical picture as well. In this patient, we use the anterior open wedge technique, where the lower disc spaces, cervical disc spaces, were open, and 3 cages were inserted to create the lordosis, and this is the clinical picture afterward. Thank you very much for attending this lecture.